We're going to bring on our next speaker, Dr. Sarah Reid, pediatric emergentologist from Ottawa, and she's going to go right now.
Thanks a lot. Okay, great. Thanks. So great to be here. So I thought today we'd talk about 4 really common clinical scenarios that can sometimes go sideways on you. And I'm just going to try and give you a couple of little pointers to maybe add into your bag of tricks. And so really this is about, if you want to really set yourself up for success here, this is about sort of anticipating what kind of trouble you can get into, having a stepwise plan developed in your mind, and really talking to the parents about that so they have a roadmap of what to expect, and that can really help prevent the gong show. So the first case is a 2-month-old boy with bronchiolitis and poor feeding. The mom has brought him in really around the feeding, not doing well, decreased wet diapers. The vital signs are actually okay, but he does look a bit dry, and so the two of you together come up with a plan for IV rehydration, and then you're going to see how it goes. So you write the order, you go off, you see a few more patients, and then you're called back into the room because the mom is super upset. And you go in to talk to her, and lo and behold, the baby's had 5 pokes, no IV. Has this ever happened to anybody here? Happens at our place all the time. And you kind of think, I wish I'd known earlier. I wish I'd talked to her about how difficult an IV start can be in a small infant. I wish I had had a different plan. And so what I would say to you is that there is a Cochrane review just published last year by Gill that talks about NG rehydration versus IV in this patient population. So it's really for hospitalized infants with bronchiolitis. 2 studies, one big, huge one from, with 759 patients. That's a very big study in pediatrics, by the way, coming from Australia and New Zealand, randomizing the babies to either IV or NG. And there was really very little clinically important difference between the 2 methods of rehydrating these babies, other than there was a very good first pass success for the NG versus the IV. Of course, this study was done at pediatric emerge sites, so these numbers are going to be different and lower if you work in a general emerge where you don't have as much, what am I trying to say? As much experience doing the IV. Thanks very much. It's been a while since I spoke to an audience, obviously. Anyway, so I think this is something that we're really behind in Canada. You know, in the UK, this is like first line for babies with bronchiolitis. We know bronchiolitis is the most common cause of admission to hospital for babies. In Australia and New Zealand, and their guidelines for bronchiolitis, it's NG all the way. So I think this is something that we should add into our list of things that we can offer to parents. If you talk to our nurses about how to do this, you swaddle the baby. You measure the tube before from the nair to the earlobe to halfway between the xiphoid and the umbilicus. You can put the NG into ice for 10 minutes before you insert because it stiffens the tube and makes it easier. You can give the baby a little bit of sucrose. We use 24% sucrose on a pacifier so they suck and swallow during the procedure, and then you just need to go for it. In terms of placement, most places don't absolutely require a chest x-ray. If the measurement is correct, it went in easily, the baby is stable, and you get a gastric aspirate. In the hospital, the Children's Hospital in Auckland, they use 5 and below, you're good to go in terms of pH. You can go ahead and feed the baby through that NG tube. You could start with just continuous Pedialyte in a syringe pump and run it at maintenance. And that would be a great thing to do. Some of them, you know, I'm sure you're thinking these babies are the ones that are going to get admitted. I'm calling peds to come down and see them. You can get this started in emerge. So I think that's something that you can offer parents. So our second case is a 50-day-old girl with fever. So we know that 10% of these febrile young infants will have a UTI, so we're going to want to check her urine. And you guys probably are aware of those guidelines that were published last year in August looking at the well-appearing baby with fever. What do we need to do for them, the young infants aged 8 to 60 days? So for this 50-day-old, we know now for the 22-day-olds and above, we can do a 2-step screen for the urine. And because there's only about 10% are going to have a UTI, this is going to obviate the need for that catheter, which is a hard thing to do if your team doesn't do it a lot, stressful for your nursing colleagues, difficult often in a little girl, super stressful for the parents. So if you have to go back into that room with an unsuccessful cath that's been tried a few times, it's not necessarily a conversation you really want to have with them. So explain to them that it's a two-step process. We're going to collect the urine in one of two ways. The urine bag, which you guys are probably very familiar with, and then a clean catch void. And in the last few years, there's been a number of studies looking at how can we stimulate a void in a little baby. There's the hanging technique, massaging their back, but I'm going to show you a video of probably the easier one called the quick wee method. So we're hoping that this video is going to play. Amazing.
Quick wee is a quick and simple way of collecting urine samples from very young children who are not yet toilet trained. And this is important because urinary tract infections, or UTIs, are common in this age group. But collecting a sample to check for UTI can be difficult and very time consuming. And so with the quick wee method, we clean around the urogenital entrance, then we use cold fluid to soak a piece of gauze, and we rub the lower part of the abdomen in circular motions to trigger those bladder reflexes, and have a cup ready to catch a urine sample when they pass urine. In our trial, 1 in 3 children had a sample collected within 5 minutes.
So this is a way that you guys can put this into your practice where sure you can use the U-bag, but you could prep the baby's perineum as if you were going to do a catheter, stimulate the little suprapubic area with cold, wet gauze, try and catch a urine. Amazing. The contamination rate is half that of what's in a urine bag. And then if you are unsuccessful within that first 5 minutes, you can put the urine bag on as usual. So another option for a non-invasive way of checking urine in little babies and hopefully really decreasing the amount of catheterization we need to do in those little ones. Okay, so our third case is an anxious 6-year-old with a laceration. So I don't know if this has ever happened to you, but maybe our approach at our shop is to do multimodal pain control, of course. So this kid has had some Advil at the door. They've had lidocaine, adrenaline, and tetracaine put on their laceration. I go in to see, it's a biggish laceration, so I think I'm going to want to put some local in there. It definitely is going to need sutures, so I can't really use my tissue adhesive or my steri strips. So this 6-year-old seems pretty chill, so I just, talking to them like I would, around the needle, and I lose the room, complete freak out. It's just a disaster. The parents are looking at you like, oh my God, like, have you been doing pediatrics for a while? And so what I think we need to add into this stepwise approach you probably already use, you're probably gluing lots of cuts, you're using steri strips, you're using absorbable sutures, because if it's stressful to get the sutures in, it's very stressful to get the sutures out. So in peds, we almost always use absorbable sutures. But the thing that you could add in here is anxiolysis. So there's a few different things on offer in terms of what you can use for anxiolysis. There was a CGEM study published from a survey looking at it from PEM providers across Canada. Would you offer anxiolysis for a 3-year-old who needed a lac repair? And 78% said yes. The majority would use intranasal midazolam. I think at our shop, and what I'm hearing sort of anecdotally from my colleagues in other places is that a lot of people use fentanyl and midazolam together, and that's what I do, because I think it just gives you a little bit more control over the situation. We're using an atomizer. We're using the higher concentration midazolam. Midazolam is very irritating to the mucosa, so we give the fentanyl first. In terms of monitoring, what we do is we do a pain score and vitals. We give the 2 medications, and then they get, because they've had intranasal midazolam, we do Q10-minute vital signs times 3. That's probably different at other places, but that's sort of what we do at CHEO. So I think, there's intranasal dexmedetomidine that's sort of coming on scene. There's nitrous oxide. So this is a bit of a use what you know what you use situation, because there really isn't evidence at this time telling us what exactly is the best agent to use for the best indication. So I have the doses there for you, and something to consider. I would offer it to parents. They may not go for it, but just doing that simple communication of these are the things we use to control pain and anxiety and emerge allows them some agency and really decreases their distress when they watch their kid getting a procedure. Holding a screaming kid down is really out of favor, okay? It's going to really we did used to do that quite a lot. We had this board where we would strap them to a board when I was training. It's really not on. It sets them up for healthcare avoidance. It sets them up for pain amplification. It's not good. So I think we can do better by those little guys with painful injuries. The last case I'm going to talk to you about is a 10-year-old with autistic spectrum disorder and agitation, so a behavioral emergency in this population. And we know that these kids have a 10 times increased rate of using emergency services, so we need to get good at this. And this is a situation that causes the families an inordinate amount of stress because they're always so worried of taking this child into a very highly stimulating environment like the emergency room, and they only come if they really need our help, okay? In 2019, there was a consensus guideline published by 2 groups in the States, like emergency psychiatry and pediatric and adolescent psychiatry, basically giving consensus, basically expert guidelines on what we should use for different circumstances that cause agitation in children. There's not a lot of evidence in this area. It's really based on, as I said, expert consensus. And in your handout, I included just a little screenshot. Their focus initially is on the behavioral techniques that we can do. And of course, if the severe agitation persists, then we need to use medications. And it's really etiology based. And that document is sort of a foundational document that we've used at TREC, developing a Canadian guideline with some experts from the States that'll be published in the next couple of months. So I'm just going to show you a couple of screenshots of what it looks like. It's like the other algorithms that hopefully you're using from TREC as well. Across the top, it does go through some examples of how you can manage the environment. So for example, no time in the waiting room, into a quiet room, lights down, low stim, low noise environment. Different suggestions around behavioral de-escalation and calming interventions that you can do for these agitated kids. It then really moves on to talking about different etiologies for agitation. So in addition to the developmental delay ASD spectrum children, it will include things like withdrawal, psychiatric disorder, and that sort of thing. So the meds that you're going to choose is very much related to what you think the etiology is. And so for this kid that comes in, the mom is able to give you a full report. So using the caregiver as the expert on the child is key to engage her right off the top. She'll be able to tell you exactly what she thinks is going on. She'll be able to reassure you that she doesn't think this is related to pain, that the child's been systemically well, that he does this when his routine is changed and something happened at school today that seems to have triggered him. She's seen this before. She'll be able to tell you what medications he's on, has he ever had a PRN given, how did it go, what's worked before. And that's all extremely important information that you're going to use to make a decision about what your next step is. Because if the behavioral de-escalation techniques haven't worked, we're going to have to move on to use medication to try and calm and decrease the risk to both the patient and to the staff. And so for each etiology in the algorithm, we link it to medications. This is a draft, of course, but the 3 medications that are sort of recommended orally are clonidine, risperidone, and olanzapine. Olanzapine is a very nice option because it's still available as an oral dissolve or disintegrating tablet, whereas risperidone we used to have that option. It's not available anymore. We really try and avoid benzodiazepines in this population because they do have an increased risk of disinhibition. So unless it's worked before, I would not use a benzodiazepine in this kid. And we really, really try and decrease the intramuscular injection in this population. So almost always really trying oral, and that's why the oral dissolved tablets are a really good option. And you'll see in that last bullet that one really helpful tip is that if the child's on medication at home, you could always do an extra dose, a half or quarter dose of the med he's on at home. So for example, if this is a child who's on risperidone for behavioral management at home, at 0.5 milligrams, you could give him an extra half dose of the 0.25 milligrams in emerge and see how you go, making sure that you're below the max dose. The other option for him, because of that oral dissolved tablet issue, is that you could easily just give him a dose of olanzapine with the ODT and see how we go. I would let the parent give you some really good advice about what they think is going to work. You might even have the parent administer the medication because she'll know exactly what the best way is to get the medication into her child. And with the algorithm, we're going to have a hyperlinked document that will have a dosing table that will give all the tips about what to give, what your max doses are, and what to be watching for in terms of cautions. So I'm hopeful that this PEDS-PAC algorithm that'll be available in the next little while will be a helpful tool when you're dealing with this population that are at such high risk of having negative experiences and emerge. Thanks very much.
Thank you, Sarah. I remember when they first came out with the board, it was like a cartoon rocket ship, because kids love being tied to cartoon rockets.
Yes.
And
yeah,
I had a
yeah.
kid screaming, get me out of this effing rocket, whatever. And I just remember thinking, one less astronaut candidate.
Yeah, that's fair. Yeah.
So I think we're going to call it there, and we're going to bring up our next
Okay, great,
speaker
thanks.
for right now.